Good morning to everyone. I'm very happy to be here. And yes, to be honest, Alessandro gave me a very long title with a lot of stuffs in that. And I tried to come up with a single title that it's, I hope, clear with respect to what I would like to talk with you in these couple of hours. So what we are focusing in is, sorry. Is what we can call secondary and tertiary literature. You probably have understood during the first days of this school about the pros and cons of medical literature and research papers. So what we are going to do today is to take this information and try to elaborate the information in documents that help us in reaching decisions. As Alessandro was saying, I'm part of this Center for Regulatory Policies at the Mario Negri Institute, and we work basically in between clinical research and policy decisions, especially with pharmaceutical products. That's why we are very much interested in taking the best evidence possible from research and using that research evidence to come to decisions. It's more or less what a doctor is doing during his practice or her practice, okay? I'm a clinical pharmacologist as a background. I'm a pharmacist, so I'm not a doctor. I'm not a statistician, so I'm really in the middle of all these different disciplines, and I'm not an expert of anything, so please be nice with me. So this is the outline of the presentation. As I was telling you, we have a lot of things to discuss today, so I will try to be fast as much as possible, but please, if there's something that is not clear, please interrupt me and don't be shy. So we will start talking about narrative and systematic reviews, and then we will have some details on what is a meta-analysis without going too much into the details. And this is what we can call secondary literature, and then we will move to tertiary literature, so clinical guidelines, information summaries, HTA reports, and at the end of the presentation we will have some tips on how to do a good research strategy using the medical databases. So first of all, I have no conflict of interest, especially I don't have financial conflict of interest in relation with this presentation. I might have a lot of intellectual conflict of interest, and you will probably understand that along my presentation. So this is my mom. My mom is 80 years old, and she's recently received another prescription. She's a multi-morbid, multi-treated older woman, and she got a prescription of vitamin D because she was feeling very weak and with a lot of back pains, a lot of problems in movement and so on. So we will not discuss, and at the end of this presentation we will not say if that prescription is okay or not for my mom. This is something that the doctors do. What we would do in this presentation, we would try to understand how we can answer to a lot of questions that can be framed from that specific clinical example. And where is the information, where is the evidence we can gather to help us in the decision. These are just some of the questions that can be framed from the clinical case of Teresa. We might be interested in understand if we need to test her blood level of vitamin D before starting a prescription, starting an intervention. If there are several interventions, several drugs containing vitamin D, which is the best one for her? Should Teresa take calcium too with her vitamin C? What I can expect from the treatment? What can I tell to my mom? Oh, mama, you will be better in this or that, which is the outcome of the intervention. And of course, are there side effects? And finally, but we can go on and putting other questions here. Do I have problems with interaction with other drugs, or problems linked to the fact that the kidney function is not properly functioning, or the liver function is impaired, and so on? So the first thing, this is just the premises of the discussion. The first thing I would like to stress is that we are, and you all know this very well, in a overload of information. We have too much information, medical information, but this is applicable probably to all the different fields of science and of life, I would say. And we need something that helps us to reduce the work we do to find an information, but at the same time, something that helps us to get the right information. So the information that it's useful because it's relevant for my question, and an information that it's valid, meaning that it's true. As much as possible true. We cannot say what is the truth, but we could be close to the truth if the methods that we apply to generate that kind of information is sufficiently robust, okay? So this is in a very fancy definition, what we call information mastery, so the handling of information for decision making. And the first classification we can do, that it's very basic, but it's useful for the beginning of this talk, is that we can divide research papers or research outputs in primary studies, so publication that reports original data produced by researchers, so publication of RCTs, observational studies, case reports, whatever you can think about being a research process or project. And then we have secondary and tertiary literature, meaning a collection of primary studies done following some of criteria that we will see in the presentation. And then a further elaboration of this collection, more close to decision making. Okay, all of you probably have heard about systematic reviews. All of you have heard about clinical guidelines, HTA, health technology reports. Is it true? Does anybody of you know about clinical guidelines and systematic reviews? Yeah, okay. So why we need secondary and tertiary literature? This is very simple, because we have too much information. So we need something that is a synthesis of all the information we have. But this is not just the main reason. It's not just to summarize evidence. It's to summarize the good evidence and to stress where are the gaps in the evidence generation. So a very important objective of secondary and tertiary literature is to recognize and try to mitigate that it's biases. So mitigate means you will not remove the biases, okay? Secondary and tertiary literature cannot fix problems in primary studies, but they can highlight the biases and make that biases more clear to the reader. Okay? Third advantage of secondary and tertiary literature is the increase of power of the estimates, because we put together studies, we put together different observations of the same phenomenon, and this allows us to have more precise estimate of an effect. This is statistics, but this is also simple reasoning. If you look at the same phenomenon 2 times, 3 times, 4 times, and you put together your experience, you get something that it's more well-defined, right? So it's not just statistics, it's common sense. And the fourth point is that these documents are written and framed to support decision. So for instance, clinical guidelines are usually framed on clinical questions. Does Teresa need a prescription of vitamin D because of her back pain? That's a question. We will try to address this question in the next slides. Just to spoiler a little bit, a good systematic reviews includes evaluation of the risk of bias of the single studies included. So in that sense, you will highlight all the problems in the methodology of the primary studies you are including in the systematic reviews, and you will report these problems in the systematic reviews. But we will try to address this later. So basically what secondary and tertiary literature do is to translate information in knowledge, okay? This is very theoretic, but we can use it as a background. Okay, you might be familiar with this kind of conceptualization of evidence. What is the best evidence? You might have seen this pyramid, with different layers, but basically what this pyramid says us is that our ideas, the idea of our professor, the idea of our opinion leader is at the bottom of the pyramid of knowledge, pyramid of evidence, because it's the more biased type of information. Not because our professor is a bad professor, but because he has, or she has, a prejudice, may have a partial knowledge of the literature in a given field, might have conflicts, and so on. So, going from opinions, anecdote, through all the different observational studies up to the best research design, that is randomized controlled trials, and to the very top, meaning the combination of different RCTs, we used to elaborate this kind of best evidence. So at the top, systematic reviews and meta-analysis have the best quality of evidence. This is very simple. This has been used a lot, but this is too simplistic. It's clear. If we want to study if cigarette smoke causes cancer, we cannot, of course, randomize people in 2 groups. One group is the smoker one, and the second group is the non-smoker one, by obliging people to start smoking if they don't smoke, okay? So it's not true that the RCTs are always the best study design. For sure, the best study design for answering to intervention question. Does is A better than B in that disease, okay? So we use this classification, but what you need to consider always is that the first thing is to have an important question, research question, and then apply the best study design for that type of question, okay? This is a paper published more than 10 years ago by John Ioannidis, and it has a very provocative title. You might have seen this, maybe also in this school. Why most of the published research findings are false. And Ioannidis really provided an empirical demonstration of why what we are reading in the medical journals is often, not always, but often false. And here I summarize some of the problems. First of all, a lot of studies report very small effect size. So if the effect size you are measuring with an experiment is very small, any type of distortion that you can have in your design or in your conduction or in your reporting can move this very small effect from being true or being false. If you are studying antibiotics for pneumonia, of course the effect of this type of drug is so big that even if you have some kind of biases, it's unlikely that the biases will give you a completely different results from what is the truth, okay? Another problem is that there is a lot of flexibility in methods, definition, outcomes, and again, this kind of differences can move and can provide results that are not the good ones. There are financial and other interests that can interfere, and there are areas of research that are more hot, where people are more, let's say, willing to publish and willing to publish positive research results. Sorry, so results with a statistically significant estimate. Okay, so all these are pressure that makes published research sometimes very flawed. John Ioannidis also provides some solutions or some possible solution, and among these solutions, one is to combine the data, highlight the biases, and improve, of course, the method of research. So that's why we are talking about putting together studies in reviews and in meta-analysis. So the first level, the first idea of putting together studies is what you all know, the chapter book. The chapter book is the typical narrative or literature review. An expert, usually an expert in that field, write a summary by putting together narratively, usually, the results of different studies. Okay, this is something very common. We used to study on that kind of literature, and that's okay. It's really useful when you have to answer to background questions. So I would like to know how is the mechanism of diabetes, or to understand a class of drugs, okay? In that kind of question, in that kind of knowledge, narrative reviews are very useful. They are less useful if you want to take a decision at the bedside or at the policy level, okay? This is an example of a narrative review examining 10 beliefs about vitamin D in older people. And I hope you can, well, you don't have to read the text, but just to understand the structure of the document, it's really narrative by definition. So there is a list of studies. They distinguished the observational studies from the systematic reviews. They describe the studies, and then they draw conclusions. Okay? The bottom line is, on the basis of that literature, I can say you that vitamin D reduces fractures in older people if taken for, I don't know, 6 weeks, okay? So it's useful to understand the problem and to get some information, but what is the main drawback of a kind of review like that? Does anyone have some idea? Okay, correct. Here we don't have a lot of information about the methods that bring us to that kind of conclusion, results and conclusion. For example, you cited the key issues of the methods of the reviews that are how you retrieve the evidence, why you decide to include or exclude a given study, and so on. So this is really what systematic reviews add to literature reviews. A systematic review, a good systematic review, we will talk about bad systematic reviews during the presentation. A good systematic review is really a research project. So, as any research project that can have this name, it has methods. It has a pre-planned definition of the objectives, and so it's an attempt to overcome the problem that your colleague was rightly mentioned before. So the definition is very simple. The systematic reviews is a collection of empirical evidence coming from different studies or different sources, not just studies, that fits with pre-specified eligibility criteria. And as I was telling you before, it's useful especially to answer to foreground questions, meaning, is this working in that condition, for instance, okay? So it's the tool to bring us to take decision at the end. And as all the research projects, also systematic reviews should be as much as possible unbiased. Systematic reviews are retrospective studies by definition. They do not look at the future, they look usually at the past, okay? Because they include studies that have been already conducted and usually published. So it cannot fix the problems of the primary research, but as we were telling before, they can highlight it and try to mitigate it. So this is a silly representation of what is a systematic review. You have different studies. The studies are not exactly the same studies, the same study, okay? They might have differences in eligibility criteria, differences in the type of intervention that it's studied, type of control, type of outcomes, etc. But they have a common objective, a common methodology, a similar methodology, sorry. So they fit under the eligibility criteria of the systematic reviews. For that reason, they can be included in the systematic reviews and they will be summarized and eventually combined quantitatively. Okay, so studies are not identical by definitions, they are similar, and the degree of similarity, of course, depends on the broadness or the narrowness of the systematic review. These are the steps of a good systematic review. Basically, the systematic review is a kind of filter that starts with a lot of records identified through a systematic search of the literature, and by applying this filter, some studies goes in, some goes out, and the output is a synthesis of the studies with some conclusion and a plan for dissemination. So if you start from the very beginning, the first thing of a good systematic review is to define the question of the systematic review. The narrative literature, the narrative reviews usually have a very broad question. You want to discuss about vitamin D in elderly people, okay? We will see in a comparison between narrative and systematic review that usually systematic review have narrow, more narrow objective. So you define the question, you plan the eligibility criteria, so which are the studies that goes in and which are those that goes out. You plan the methods, meaning how to extract the data, how to evaluate the quality of the study, how to combine the study together, how to present the results, and how to draw conclusion. And the 10th point, it's very typical for, very, very often applied for Cochrane reviews, but it's also something very important for other type of reviews. It's updating. Of course, you know that there are a lot of studies coming out every day. So if you do a systematic reviews today, probably in 2 weeks or 2 months, depending on the field you are working in, the results may be outdated because new studies come. So what is requested, at least for Cochrane reviews, is to keep the systematic reviews updated over time. Yes? Yes, this is a very good question. Usually, systematic reviews, at least in the past, were done only with published research, so published data. But systematic reviewers were probably the first people in the world starting to think that this was a problem, because we all know that a lot of research is not published, that is not at least published in medical journals, and it's very difficult to find. So a study is conducted, maybe it's also concluded, the results are there, but they are not published in a public journal, So the same systematic reviewers started to think about this, that it's called reporting bias, that the studies that are published are different from those who are not published. Because if it was a chance, I mean, it's just because the researchers moved and changed their university or stopped working in that field that it's not published, this would not be a problem. Because by chance you could have a positive study published or a positive study not published. But the problem is that systematically, those studies that are not published are those negative or neutral studies, meaning that they don't show a difference between the intervention and the control. So what you are doing with systematic reviews, if you stop your search to publish data, is that you amplify, you magnified the positive message of the published studies, and you do what we call the reporting bias. You amplify the reporting bias. So yes, if you are doing a systematic reviews, especially with drugs where there are other type of information sources where you can take information about trials that are not published in medical literature, it's strongly advised to look also to unpublished studies, for example, gray literature, theses or abstracts at congresses, other type of resource. I probably included one slide on that later on. And also regulatory or policy documents that might have trials that are not published in the medical literature. Did I answer to your question? Because the answer was very long, I'm sorry. Okay. Okay, this is an example of, going back, sorry. Point number 7, to answer to the first question we have from you up there. So assess studies for risk of bias. It's something that it's really crucial for a good systematic review. If you read a systematic review where there is not a formal evaluation of the biases of the included studies, you should be disappointed at least, and probably you don't have to consider that systematic reviews as a real driver of your decision, okay? Because it's clear that if you don't highlight the problems of the primary research you are including in your results, you are just putting together studies without any critical appraisal, any critical analysis of the results you are including. There are tools to evaluate risk of bias for RCTs, for observational studies, for diagnostic accuracy studies. So depending on the different type of study, you have different tools to apply, different checklists, different concept, because biases are different depending on the different type of study. Other questions? No? So this is an example of a systematic reviews, again on vitamin D supplementation in people with musculoskeletal problems. It's hard to see it, but if you look at this is the abstract. It's not a Cochrane review, it's a review published in a medical journal, one of the Lancet journal. If you look at the structure of the abstract, it's really similar to a research paper, meaning you have a background, you have a method section, very long. It's almost half of the abstract. So the emphasis put in the methods here, it's huge. Because you need to appraise the methods of the systematic reviews to be sure that the results of the systematic review are sound. Okay? Then you have the finding and the interpretation of the findings. This is a table, a comparative table between systematic and narrative review, just to highlight some of the things we have discussed so far. The main difference is that systematic reviews apply explicit, transparent, and reproducible methods, while narrative reviews are more broad in the scope and more, I would say, prone to inclusion of personal opinion rather than elaboration of evidence. Okay? And usually the format is different, so you can easily recognize the difference between a systematic review and a narrative review. But as I told you, there are also bad systematic reviews, so don't stop at the title or at the abstract. If there is written that it's a systematic reviews, you should have a look at the method section. You should recognize at least the majority of the points we discussed before to be sure that that's really a systematic reviews, okay? Okay, so you might have seen in the title of the Lancet systematic reviews that that systematic review included a meta-analysis. Who knows which is a meta-analysis? Just raise your hand if you heard about meta-analysis before. Okay. Do you think that it's a synonymous of systematic review? Those of you that heard about, no? Okay. Sometimes you find in the literature, but also by talking with colleagues, also with senior colleagues, that they use meta-analysis and systematic reviews as synonymous. This is not totally correct, because the meta-analysis is just the statistical methods that is used in systematic reviews, but also outside systematic reviews, to combine quantitatively the results coming from different studies. So the systematic reviews is the whole process we discussed before. The meta-analysis is just the quantitative combination of results. And it's a statistical method, because the combination is not done by summing the results, but it's a weighted sum of the results. More, the studies with more information are more important in the combination, so in the meta-analysis of the results. We will see it later on. Why we combine quantitatively the data, which is the main objective of this combination. It's in the slide, so it's really a rhetoric question. What we want to achieve is a more precise estimate of the effect. As I was telling you before, we look at the same phenomenon by adding information, quantitatively information, and what we gather from that, it's a more precise, meaning more confident estimate of an effect. Another objective of a meta-analysis is to provide a kind of investigation of the consistency of the effect. Because I told you before, we are including in a systematic review studies that are different, not too much different, but not identical, right? The squares were of different shapes because studies are different. In the meta-analysis, we can explore if these differences are linked to the effect. If, for example, giving vitamin D to people older than 65 years old as an effect, while giving it to people younger than 65 years old, for example, is linked to another outcome. So be careful, because meta-analyses are not always appropriate if studies are too different. If technically the word is heterogeneity, if the heterogeneity among the studies is big, combining them in a quantitative estimate is not appropriate. Of course, it's not easy to define what is enough similar to be combined, but this is something that a good systematic review plan in advance before seeing the data. You should plan when it's appropriate to make a meta-analysis or when it's not. So that's why not all the systematic reviews have a meta-analysis in it. So just to summarize, we have the world of literature reviews, just putting together studies coming from different sources. In this big world, there is the world of systematic review, so real research projects with a clear objective, with a clear protocol, clear methods, and clear way to present the results. And within systematic reviews, you could have meta-analysis. Do you have questions about that? No? See? Well, I think systematic reviews are not useful if you want to have a general idea of a field of medicine, or about, I always deal with drugs, so about a class of drugs, because usually, it's not always the case, but usually systematic reviews have a very narrow objective. For example, they usually compare two classes of intervention, and you might have several interventions for that disease or condition. So narrative reviews are really useful when you start approaching a field and you want to have a flavor of what is going on in the field, without the idea to bring the results of the narrative reviews and make them actionable, let's say. So there might be other kinds. For example, if you are interested in knowing the epidemiology of a disease, you could have meta-analysis and systematic reviews of epidemiological data, prevalence data, and so on. But maybe you could start with a narrative review that illustrates you how is the prevalence in Italy, prevalence in other European countries, prevalence in Asia, and so on. So the big difference is really which is the question you are trying to address. If it's a background question, narrative reviews can help, but this is probably the starting point of your study. And the second issue is that it's easier to write literature review than produce systematic reviews, of course. So that's why in the literature you have a lot of narrative reviews. Nowadays you have also a lot of systematic reviews, to be honest. But Okay, we were talking about meta-analysis. This is one of the meta-analyses included in the Lancet systematic review. How many of you have seen a diagram like that before? This is called forest plot, the same that knows about meta-analysis, of course. This is called forest plot, forest like the forest, because in the imagination we could see the different horizontal lines as trees. This is really philosophical. And the whole picture as the forest. So what are the horizontal bar? Just say what you think. Not you, because you know that. What do you think it's? We are talking about combine different studies in one synthesis, in one meta-analysis. So what do the horizontal line represent? Does anybody have some idea? Yes, but just look at the lines, I mean, from the beginning to the end. Lips at all, what is lips at all? It's a study, okay, so each line is a study, okay? And your colleague was very much advanced. For each study, you have a square and an horizontal line. What is the square? The square, the black. So the results of the study, exactly. So the black square is the result of each of the study, and the horizontal line is the uncertainty linked to that estimates. So by convention, the 95% confidence interval. So you plot all the studies included in your systematic review, included in your meta-analysis, and at the end, the black box, the black square at the very bottom is the meta-analysis, meaning the sum, the weighted sum of the effects measured in each of the included studies. So here I put some slides on how to read, and maybe it would be better to say how to construct a forest plot. Because I think if you, well, one of the goals of this presentation is to let you understand the complexity of a diagram such this one. I hope I can do it, but please stop me if I'm not clear. So the first thing you have to understand is that you have an horizontal axis, and the horizontal axis is the effect of the intervention. It's the statistic used to measure the effect of intervention. Let's talk in a simple way. Let's talk about a study that it's measuring mortality. Okay, so the outcome, it's a binary outcome. You could be dead or alive, nothing in the middle. So what you are measuring is a risk of not being dead. Usually you prefer to be alive than dead. So if you are before the line of null effect, meaning that vertical line, you are in the part of the diagram where you are happy because you are alive. When you are in the right part of the diagram, you are not happy because you are dead. So what this diagram will represent, it's the difference between being treated and being alive, or being treated and being dead. This is the risk of being dead, okay? Or the odds, but okay, let's talk about risk. So the effect is the horizontal axis. Then every time you see a study, so the estimate or its 94% confidence interval touching that vertical line, it means that the difference is not statistically significant. So let's talk about A, the study A. What can we say about the study A? It's mortality, so would you prefer to be treated with a control or treated with a treatment, with the intervention, according to study A? No difference? Because But what about the estimate? Just forget about the 90% confidence interval for a moment, but then remember it. What about the estimate? What is the estimate, the point estimate of that study? Of the study A, yeah. So you would say that if you forget for a moment about 90% confidence interval, okay. Do you all agree with that? But of course, you cannot forget the uncertainty of the estimate, so your answer was totally correct. The study A is not statistically significant. It does not demonstrate a difference between the control and the intervention, okay? What about study B? Now it's easier. Maybe someone else could answer. Do you prefer to be treated with intervention if you are in a study B, or do you prefer to be treated with the control? I agree. And in that study, you also can say that that difference is statistically significant because the 95% confidence interval does not touch the null effect. What about that? It's not C, but the middle one. That's the worst situation you can have, no? Because you are in the part where it's better to be treated, but again, the 95% confidence interval touches the line of null effect. So again, that study is not statistically significant, although the point estimate is in the part of the diagram that it's related to the, let's say, benefit of the treatment. Why the three studies have different length in their 95% confidence interval? I always look at him, but you are free to answer. Why the top one is less, the line is less long than the others? And if you look carefully, the square is bigger. Our fancy artists and we draw differently because we like the plot different, or do you think there's a reason behind that? Bigger cohort of patients? Yeah? It's a list of reasons, or are you just proposing that? The first one was the right one. The difference is only linked to the sample of the study, or to be more precise about the information size that that study brings into the meta-analysis, and usually it depends on the numerosity, on the sample of the study. So study B, it's bigger than study A, for sure. The more the 90% or 95% confidence interval is narrow, the more precise is the estimate, and usually the bigger is the study, okay? We still don't have a meta-analysis there. We just have plotted the three studies we want to include in our meta-analysis. So let's try to guess, where is the meta-analysis there? I mean, if you have to mentally put together the three studies, where is the combination, the effect of the combination? Where do you think? Would it be in that part, on the null effect, just try to figure out where is the diamond, because usually the meta-analysis is plotted as a diamond. Of course, you cannot do it. The software will do that. Sorry, okay, but just to let you understand the reasoning behind. Probably because, sorry. Where is, why you said that? So is that clear? I mean, your colleague is correctly saying that the two studies are in the left part of the diagram, and especially the first one is the one that weighs more, because we said that meta-analysis is a weighted sum, okay? So his guess is that the diagram, the meta-analysis will fall into the left part of the diagram. He's more concerned about the uncertainty. So he said, I don't know if it crosses or not. But one thing is, you can know one thing without knowing if it's cross or not. What can you tell me about the confidence interval of the meta-analysis? Would you expect that it's bigger than the other, smaller than the other, equal? Exactly. So the effect of the meta-analysis is to increase the precision of the estimate. So the 90% confidence interval would be smaller than each of the single studies you are including. Okay? Here I add another couple of studies, sorry, but the diamond is the meta-analysis. And you could see that it's in the left part of the diagram, and the interval, the confidence interval, so the two lateral boundaries of the diamond do not touch the line of null effect. This is how a real meta-analysis looks like. Of course, there are a lot of information there, but you have basically seen with these few slides all the main building blocks of a meta-analysis. So each line is a study. You have a graphical plotting of the results and a numerical one. Okay. You have the meta-analysis at the very bottom, that it's the weighted sum. You have here, I think I have a pointer. Yeah. You have here the comparison, the title of what you are comparing in this meta-analysis. In this case, is amitriptyline versus placebo. So here we have placebo, here we have amitriptyline, because the outcome here is not a negative outcome, but it's a positive outcome. So you need to be careful on what is the outcome you are evaluating, and so what is the statistics that combine the different effects, okay? What you have here, without going too much into the details, it's what we call heterogeneity, so the difference, an estimate of the difference among the study. It's usually measured by an index that it's the I-square index. Every time you see very big I-square, you can conclude that the studies are heterogeneous. But without knowing anything about the I-square, you could also see that these studies are different because, you know, someone are very close to the null effect, others are more far, okay? So by just an inspection of the different studies, you could say that these studies are different. This is just a test, statistical test that provides you a kind of quantitative measure. And these are differences not due to chance, but due to through differences among the studies. Differences in type of participant, different in types of outcome measures, settings, whatever you want, okay? Is there any question on that? No? Okay. So, if you like meta-analysis, you would like individual participant meta-analysis too. In the meta-analysis I showed you before, what we are combining are aggregate estimates provided by each of the studies included. So the risk ratio in study A with the risk ratio of study B, and so on. What we can do with our individual participant meta-analysis is putting together the single observation done in the different studies. This is an evolution of meta-analysis, of course, that you can only do if you have individual participant data available. This is not always the case because the publication we usually include in our meta-analysis are publication of aggregate data, not individual data. But sometimes you have access to IPD, individual participant meta-analysis, individual participant data sets, and you can combine directly the single observation done in each single study in a global estimate. Of course, this has some statistical advantages. Power is increased, heterogeneity is usually reduced, and so on. And also you can explore questions that were not explored in the original studies, because, for example, you might have an interest in a given subgroup of a study rather than the whole cohort of studies, of patients. This is an example of a vitamin D and mortality individual participant data. Here the authors are part of a European consortium of researchers. They put together their own observation done in different studies in a single individual participant meta-analysis. Of course, this is more complex, more time-consuming. You cannot do it for all the systematic reviews, okay? But in some cases, it is helpful. Another evolution of meta-analysis is a network meta-analysis. So if you remember, the first meta-analysis I've shown you was amitriptyline versus placebo, just a pairwise comparison, A versus B. What we can do with network meta-analysis is comparing different treatments, more than 2 different treatments at the same time. And we can do it by putting together direct comparison, meaning studies that compare A to B, with indirect comparisons. So meaning studies that, for example, test A and B, A and E, but if I don't have any study that compare B and E, I can make this indirect comparison on the basis of the network I've created. So it's, again, something complex, very, very difficult to achieve, but now there's a good statistics that allows you to put together direct and indirect evidence. Of course, this is really interesting for clinicians and decision makers because it's, well, maybe not always, but very often the case that a clinician or a policymaker has to decide among different options, not just between 2 options. So this network meta-analysis can help taking decision in complex situations where you have more than two interventions. What you should be very careful to do is to make ranking. So you have a lot of intervention for a given disease, and with network meta-analysis, the temptation is to say the first one is this one, the second one is this one, like a ranking, okay? This is sometimes possible, but very often it's misleading. So what I suggest you is not to use network meta-analysis to make ranks. I don't know why the microphone is doing that, but okay. Okay, this is just to give you some information about something that it's really complex. Of course, we cannot talk about the details of that. So when I talk with about systematic reviews, I always have the impression that the world is divided in two parts. We have people very happy about systematic reviews, like me, and people saying that they are the magic bullets. They can do everything. They can inform practitioners, policymakers, consumers, people doing new research, because with the systematic reviews you can highlight where you need to do further research because you don't have data, right? And the other part of the world is people saying that systematic reviews are just putting together oranges and apples and not doing novel research because it's based on previous research. And also it's a type of publication that put together research that is flawed, that it's not good quality research. Okay, so trying to be as much as possible neutral between these two different positions, you should be aware that there are systematic reviews done not properly, so it's not an automatic reflex that you have to apply in front of a systematic reviews. You need to be critical also with systematic reviews to understand if they are conducted correctly or not. So if you are doing systematic reviews, do it right. And there are a lot of instruments, a lot of tools, like those promoted by the Center of Evidence-Based Medicine in Oxford, the Cochrane collaboration, the methods section. We do several courses about systematic review, so if you are interested, of course, we can provide you with some information about that. If you are reading systematic reviews, read it better. Be critical also with systematic reviews. Appraise the methods, and we now have a lot of systems to see if a systematic review is well conducted or not. Don't focus only on the results of the systematic reviews, because there might be another systematic reviews telling you exactly the opposite about the first one, and Alessandro is very much involved in trying to provide framework for deciding which is the good one in case of conflicts. Don't stop in interpreting just the diamond, just a meta-analysis. The systematic reviews is very much more than a diamond. It's a synthesis of the evidence. It's an appraisal of the quality of the evidence in the synthesis. Okay. It's a discussion about the relevance of the outcome measured by the primary research with respect to the outcome that are useful to take decision, and so on. So a diamond alone does not mean love in life and in systematic reviews. Of course, also systematic reviews as primary research can be conflicted. The author can have conflict of interest. So you need to evaluate the conflict of interest of the authors of the systematic reviews. And again, you might have talked about reporting of research. Of course, we are interested in appraise how the research is conducted, but we are forced to judge the conduction through the reporting, because we don't have the time machine and can go back at when the researchers did the research, but we read what they report us they do. So the issue of a bad reporting is also an issue in systematic reviews, and luckily we have reporting guidelines also for systematic reviews as the PRISMA guidelines. As I was telling you, the number of systematic reviews is hugely increased in the last years. One reason is because it's highly cited type of literature, so your curriculum will increase if you publish systematic reviews, but also because the scientific community recognizes the pros of having systematic reviews. We could have a small break if you want. Just a few words about other types of reviews that are more useful for scanning an environment, scanning an argument, an area, and to make a kind of overview of definition or boundaries and so on in a given topic. These are usually called, the names are a bit heterogeneous, but usually these are called scoping reviews. And usually these are conducted before a research program. For instance, if you start with a research program, you would like to know what is the state of the art in that field, just to be informed by the previous research. And very similar, those called environmental scan. So these are not so structured as systematic reviews. They apply some issues and some steps of the systematic reviews, but they are more a broad way to gather data and to put together data.